Good morning, everyone, or afternoon or evening, depending on where you're joining us from today. Welcome and thank you for attending today's session titled Overdose in the United States, Lessons from a Shifting Crisis. I'm Jake Dizard. I'm the Director of Research here at Pennington Institute. For those of you who aren't familiar with us, we're a not-for-profit organization that focuses on supporting cost-effective approaches that maximize community health and safety in relation to drugs. I'd like to acknowledge that I am joining today from Wurundjeri Woiwurrung country and wish to acknowledge the traditional owners of the lands where I live and work and pay respect to Aboriginal elders past and present. I also acknowledge the traditional owners of the various lands where our audience is joining from, not just across Australia, but also perhaps in North America, New Zealand, and elsewhere. A couple of brief housekeeping notes. Today's session will last for 60 minutes. Our two esteemed guests, who I will introduce momentarily, will give their presentation for approximately 40-45 minutes, and there should be time for some Q&A at the end. I encourage you to submit questions via the Q&A function that you'll see at the bottom of your Zoom screen, not to be confused with the chat function, which won't work, and we'll get through as many questions as possible, including those that people already submitted when registering. Do note that today's webinar is being recorded and will be made available on the Pennington Institute website over the next few days at the same link you used to register. And our panelists have informed us that their slides, which are very informative and well put together, will also be made available. So you can look forward to that as well. A quick content warning. The content in this webinar includes information related to overdose deaths and/or injury and the circumstances leading to these outcomes. So we do recognize that this subject matter can trigger an emotional response for some people. All right, so given our limited time, let's get started. As just about everyone in this room will be aware, over the last 5 to 10 years, but really building up even before that, the US has been experiencing an extreme overdose crisis, driven above all by changes in the drug supply. And, it really amounts to a nearly incomprehensible tragedy. So around 2 years ago, the trend line finally started to shift, which we will hear much more about. But the scale of both cumulative and ongoing loss is still quite staggering. So those of us in Australia have watched with immense sadness and feel enormous solidarity with people who use drugs, communities that have been deeply scarred, and frontlines workers throughout North America. We also recognize that while here in Australia, we've so far been fortunate to escape similarly dramatic changes in the drug supply, particularly the ubiquitous presence of potent synthetic opioids like fentanyl, it is crucial to understand what happened and how to be prepared. So our guests today are among the most perceptive and respected observers of how to make sense of what's happening on the ground, using both sophisticated data analysis and direct engagement with people who use drugs to rigorously assess patterns of drug harms and opportunities to prevent them. So to provide some brief bios before handing over the mic, Dr. Nabarun Dasgupta is a street drug scientist at the University of North Carolina with 2 decades of experience in overdose measurement and prevention. His passion is telling true stories about health with numbers. At UNC, he also works at the Opioid Data Lab, a team of science exploring difficult questions in overdose prevention. He leads the UNC Street Drug Analysis Lab, which has analyzed and searched for patterns in over 12,000 street drug samples. And in addition, he's a co-founder of Remedy Alliance for the People, a groundbreaking nonprofit distributor of the overdose reversal drug naloxone. In 2023, Dr. Dasgupta was named to Time 100 Next list of emerging global leaders with a statement reading, "Few Americans have done more to prevent drug overdose deaths than Nabarun Dasgupta." So NAB is joined by Dr. Adam Sibley, a social behavioral scientist and postdoctoral fellow with UNC's Injury Prevention Research Center. Adams uses mixed methods data to tell stories that inform harm reduction policy, prioritizing community voice and acknowledging the rapidly shifting landscape of the overdose epidemic. Adams has extensive experience developing accessible, community-engaged interventions to address the social determinants of overdose, and his current research leverages drug checking and harm reduction data to disseminate emerging trends and best practices to people who use drugs and practitioners. So again, we encourage you to post any questions that strike you during the chat to the Q&A function. And with that prelude, Nab and Adams, welcome to virtual Australia. Thank you so much for joining us, and the floor is yours.
Thank you so much for that kind introduction, and apologies for not being able to be there in person. Hopefully next time. Um, okay, slides looking okay, Jake?
Yes.
Okay, great. Thank you. All right, so you heard the summary of what we are going to be talking about today, but before we go into that, let me be upfront about our funding and our disclosures. We are at this moment where deregulation is part of what is intended to be happening in the United States, and into that space is going to into the space kind of vacated by federal and scientific agencies is going to step in industry and industry funding. So I want to make clear that we do not accept industry funding. Our funding for our projects comes from foundations and nonprofits. We have funding from our state health department as well as our legislature. And excuse me, on a federal level, we get funding from the U.S. Food and Drug Administration. We do drug checking, which is a mail-based service for where people mail us samples. We analyze them, give them the results. We do that at cost or free. And we won't be talking much about that today, but just wanted to make clear that that's what we do. And as Jake mentioned, I am a board member at Remedy Alliance for the People, and we provide at cost or free technical assistance and access to bulk naloxone and other medications. Okay, with that out of the way, our agenda today is going to be straightforward from the learning objectives, which is a brief background on the US overdose crisis, the recent trends and shifts. We're going to look into what's working and how we know what is working, or maybe we don't know what's working, and the implications for the future. I'm really pleased that Adams can join us for this talk today, and a lot of these ideas are equally his and mine. So we are just choosing which ones we know, which sections we do. I'll hand it over to Adams shortly. Okay, so let's level set here. I think this is a number that really sticks with me about kind of the moment we're in. 40+% of American adults know someone personally who's died of a drug overdose death. And this is an astounding number. This is unnatural and extremely sad. We don't often acknowledge the grief that has accumulated in our communities, in our teams, from doing this work, from seeing so many of our friends pass away. And part of the reason why we do the work we do and the way in which we do the work is because in order to have longevity in this field, we find that we have to do things that are meaningful to us and meaningful to our communities. And this is the starting point, which is really a starting point of grief. And for those of you who don't live in the United States, the burden is really unbearable. So how do we make our work meaningful? Well, we work at the Opioid Data Lab, which is a collaboration between 3 public universities in the southeastern United States. At the Opioid Data Lab, our projects are divided into 3 categories: theory, practice, and lived experience. Theory are foundational studies looking at pharmacology, psychology of communication and drug alerts, and biostatistics and epi methods. Really nerdy stuff, really cool, and but not for everyone. Our second set of projects are applied research, and this is looking at the practice of pharmacy, of medicine, and also the practice of harm reduction, but also kind of the practice of vital statistics. So how do we count overdose deaths? And finally, we have another set of projects, lived experience projects. These include sociological and qualitative research, as well as historical analyses and looking at changes in how addiction has been categorized over 2 centuries, and also drug checking work. So throughout this all, our real intent is to focus in on answering questions that are brought to us by a community. Our approach is different. We are not a pure research house. We exist outside of academic departments at UNC, and we are instead a public service of a public university. Science in service is the way we think of ourselves. Okay, so now you know a little bit about us. Let's look at the US context. Okay. So this is a very new graphic that was just published this morning by the Drug Policy Alliance, and I think ignore the text for now, just look at the graphics. Here's a very quick rundown of what has happened in the last 2.5 decades in the United States. We saw an increase in prescription opioid overdose deaths in the early 2000s. and followed by a crackdown on prescribers and opioid dispensing and pill mills. We then saw an emergence of heroin in the mid about a decade later, followed by heroin busts and an increase in enforcement against heroin. What happened next is not exactly surprising. We saw fentanyl and related fentanyl analogs come out, and there were kind of two things that happened after that. One is there was federal pressure to schedule all fentanyl analogs, which led to the emergence of new synthetic opioids and sedatives, which we'll be talking about today. At the same time, there were international changes in supply chains that led to the substances arriving in the United States at a much more rapid rate than before. This process has played out over almost 3 decades. So the same people who were in one of these buckets are not the same people necessarily who are in future buckets. And that's going to be one of the themes that you'll see as we go along. But societally, this is the pattern that we've seen. Okay, so I'm going to give you a quick rundown and as simply as I can, a very, very complicated process that is how do we count overdose deaths in the United States? This actual process we've mapped out is more like 50 steps, and I'm trying to condense it down. So we have it starts with the overdose fatality, and the suspected overdoses are referred for autopsies. And what we have is local coroners and medical examiners doing that initial assessment and that suspicion that this was an overdose death. Um, in some states, the overdose deaths are reported maybe within 5 months of actually happening on state overdose dashboards. And CDC nationally takes those data and projects them and publishes them. And those are some of the numbers we'll use today with the caveats that we'll go into at the right moment. From there, so those are suspected overdose deaths. After that, the medical legal investigation continues, and it takes about 8 months in the United States for a overdose case to be finalized, for the cause of death to be attributed, and the substances involved to be recorded. The final cause will then be registered with the state, and we have 50 states in the United States plus a handful of territories. And then the state will compile data on all deaths with about a year later and release public state data sets. And then those data finally get to the national level where we have de-identified public national data about 2 years later. So that's the usual process. Some of the data, again, that I'm going to show you today are really kind of upstream projections, which again, will go into the biases. But this gives you kind of a rough sense of how kind of where we're getting information from and when we know what. So this is the fundamental question that we started asking ourselves last fall. Are overdoses down and why? And this particular blog post that Adams and I co-wrote with our colleague Colin has a lot more detail. The link to it is on that QR code. Okay, so the first question, are overdoses actually down in the United States? So let's look at this from a few different angles. Here's the big picture. We are experiencing, so this is total overdose deaths, and so this includes suicides as well as unintentional. And excuse me, in the United States at this current time, suicide mortality from involving drugs of overdose is less than 8%. So most of what you're seeing is not suicide. Um, we've had a 29% reduction nationally since the peak in June of 2023. This is amazing. This is a once in a generation, once in 2 generation, almost 3 generation change. We're really happy about this. On the other hand, we're still losing way too many people we love. So let's look at that same graph again. Another way to interpret the same exact graph is to point out that there's been a 4.5-fold increase in drug overdose deaths from 1999 to 2024. So over a 25-year period, we've lost 1.5 million people. This is a huge, huge tragedy in this nation's history. So how do we know that overdoses are actually declining? Well, overdose data have a lot of caveats with them. And so in the United States, we have 3 parallel systems that we can look to. One is hospital emergency department visits. One is 911 or emergency calls, and then the overdose mortality. So what we're seeing if you look at the overdose mortality data, the non-fatal overdose data from hospital emergency departments, you're seeing a similar level of decline in generally in similar places. If you look at emergency phone calls for help to paramedics, you see a similar decline in similar places. So this gives us a little bit of kind of concordance that three independent data systems are seeing the same thing and converging on an actual phenomenon. But this is one of the kind of a fundamental piece of epidemiology theory that's worth pointing out. When we talk about national numbers, it only tells a very coarse story, a very high level story that often hides a lot of trends. In epidemiology, we have a phenomenon called Simpson's paradox, and this is basically the idea that that trends going up in big population places will mask trends going down in lower population places. And this is something that's well established. What you can see on the graph here is that the national overdose numbers are very heavily influenced by high population states like California and Florida and New York. And Texas as well. So what you can kind of start to get a little bit of the flavor here is that part of the reason why we're seeing a decline in the summer of 2023 is because California finally peaked and started coming down, as did Florida and a few other places. So we're going to go much more into detail with much better visualizations, but this is part of the foundational theory of what we are encountering. So kind of getting into that, was this a sudden decline is a really important question because it really changes what our implications are for causality. So if it was a sudden decline that happened all over the country at the same exact time, we would be looking at a macro force. It would be something that was ubiquitous and having pretty close to uniform or random effect across the entire country at the same time. On the other hand, if this was a phenomenon where the overdoses were declining slowly over, say, a 2 to 3 year period, and say at different rates in different places, starting at different times, we would have a much more complex picture to be looking at. Having a abrupt discontinuation like that would more strongly imply that the change might have been a supply side change, like something in the drugs themselves changed, whereas a slower decline might suggest a more community response or other more complex societal factors at play. So let's answer this question. Was this a sudden decline? One way to look at this is to ask this pretty simple question, or it seems simple to me, which is when did each state reach peak overdose deaths? And it's also, just taking a step backwards here, incredible that we have finally, for the first time in my career, the luxury of even asking this question in the past tense. We've been looking at this as a future possibility forever, and it is finally something that we can try to quantify. Quantifying it, turns out, is actually more complicated than we thought. So this is from the US CDC website. This is kind of the national data set and data display that's used for making a lot of policy and drive a lot of media and other funding decisions, questions, etc. So in this graph, you see these dots, they're the predicted values of what the overdose deaths are like. And the orange bar shows kind of where that peak is. And about somewhere in the summer of 2023, about June, July, August. And this gives you a little sense, okay? However, usually when we see dots on a timeline like this and we have month on the bottom of scale, we think of it as that's the number, how many deaths happened in that month, and we can see trends. However, that's not how these data are displayed. And again, these are really important central data for national policy decisions. But here's the fundamental problem. Each of those dots does not represent a dot. It actually represents a 12-month period, a 12-month look back. So How do we untangle that a little bit? Here's the same graph kind of blown up a little bit. And instead, on the bottom, we use a shading heat map to show you kind of the same values that we're talking about. And we're talking about at peak over 100,000, over 110,000 overdose deaths per year, which is incredibly high. Okay, so here we see it in about August when we made these slides. So, okay, what each of those dots is actually saying is here is the worst 12-month period. And that is not exactly intuitive, but is really critical to how we measure when did these declines start, when did that peak happen. And so we found that there are two ways to define peak. What is the month that had the highest number of overdoses, or what is the worst 12-month period? And both of these have really important ramifications. A sudden, when you have spikes in overdoses, that often drives a lot of media attention. It drives a lot of the direct societal response from civil society groups. The worst 12-month period is more of a helpless feeling and kind of drives people to feel like the problem is intractable. And so I think both of these play out both numerically in the epi sense, in the epidemiology sense, but also on a societal sense and in our public discourse. So here's what it actually looked like if we were using this convention. The rectangles are the worst 12-month period, and the orange squares are the worst single month. And this is just the number of counts sorry, actually, it's effectively the number of counts by state. So what you see over here is these orange squares kind of starting right at March of 2020. So there were a whole bunch of states that had an initial increase in overdose deaths that happened right when the COVID-19 pandemic happened. But there were also places where overdose deaths actually were low and went lower during that initial phase of the pandemic. So when we start, these are important concepts to get out in the open, because when we talk about, the impacts of these broader macro societal trends, sometimes they don't align to our expectations, and they're very heterogeneous across the country. What you can see from the orange rectangles kind of stepping down this waterfall is that each state kind of peaked at a different time over this extended period from about 2022 to 2024. And I think this was an exercise that really opened my eyes to the complexity of what we are dealing with. So here's another way to look at the same data, but kind of now plotted geographically and looking at the worst 12-month period and when did that occur. And what we see is that overdose deaths declined at different times throughout the country. There's some little bit of geographic patterning, but it isn't a uniform phenomenon going across the whole country. So this is what we concluded, that the US experienced a gradual decline in overdose deaths over a 3-year period, and that these declines started at different times throughout the country. Okay, so how do we measure overdose declines? Kind of really getting into the nitty gritty here. So we made this graphic to kind of come up with a different way to represent the same data. So this is a z-score. So it is red is higher than average and blue is lower than average. And we're honing in at the period January 2020 to August of 2024. And we'll show you these by state. This one happens to be Massachusetts, but it's a good kind of example of what these data will look like. The first thing we've noticed is that nearly 20 states have now returned to pre-COVID overdose mortality. And in many states, it was during the early years of COVID that fentanyl first really emerged in force. There were a few places that had it and had problems with it much earlier. So that's the first thing we noticed. And so this is, excuse me, a graph. This is kind of intended to show you kind of what the shape of these curves look like across the country. You'll have the slides and you can look at this in more detail later. What we found is that there were two patterns, A shapes and M shapes. And again, this really gets us to causality, because if we have one peak up, and then one slope down, then we would attribute both the source of the problem and the solutions or the forces that are acting against it to be kind of happening all up and concentrated at one time. So these are the states that have that pattern. kind of like I like Florida's droopy mustache look here. And this is like a very heterogeneous mix of states, East Coast and West Coast. There are places that are liberal and more conservative. There are large states and small states, but we see this similarity of visual pattern. Now, here are the other set of states, which are M-shaped. And these often show two different peaks. And so what does it mean to have two different peaks of overdose? Well, it suggests that maybe something was happening in one part of the state, maybe there's two big cities, and maybe one of them experienced the problems first and then the other one. But some of these are separated by years. And for those of you who are quantitatively minded, you know that this is a disentangling mushy peaks is a hard quantifiable thing to do. So but just to say, like, when we're talking about what is helping and what is causing changes in overdose, this shape is also really important to remember. And it could be that, things were worse, things were bad, it got a little bit better, and then things went poorly again and things increased. This is also a lesson for the future. Even though we are on the downswing now, this is a fragile recovery, and we may end up on the upswing if we're not careful. Okay, so those are kind of a flavor of what it looks like at the state level. So I'm going to return to the CDC official website and the way these statistics are calculated. And this is a technical concept, but that smoothing, you know how we're looking at 12-month bands? Well, this has a real interpretation impact when we look at things on a state level. So this is the state of Arizona, which is in the southwestern United States. It's a fairly large state with a couple of major centers of population and a lot of desert, the Sonoran Desert surrounding it. So very hot in the summertime. If you look at the CDC graph, what you will see is kind of a gradual increase, a sharp increase, and then a plateau, and then a slight bending of the curve, starting in 2023. So this is also a border state, and there's a lot of complicated border politics happening, kind of unfolding at the same time. It's easy to draw the wrong conclusion. I find this graph to be misleading. When we recast the data, looking at it on a monthly level instead of the smooth, we see a really different story. So this purple line is a recreation of the same line that you saw in the previous graph. You can ignore the blue one for now. And the orange is the actual confirmed monthly overdose deaths. So not predicted and not projected and not smooth. What you see are spikes. What you see are distinct spikes that happen in overdose mortality in this desert state in the month of July every single year. And what that tells us is that this is the problem with overdoses is A, not as high as it appears when you smooth out these data over a 12-month period, but is really something that's happening at the nexus of housing insecurity, of heat, exposure, dehydration, and a lot of other complex social things. The reason we bring this up as an example is that when we think forward to policy, what is a rational policy here? Is it to say we're staying at a same bad level for a long time and look, we're finally declining? Or is it to surge resources in the month of July, figure out who is most at risk specifically in that month, and do what you can to get these peaks down? I think the latter is a better public health strategy going forward. And similarly, in Alaska, what this national statistics and smoothing do is, if you look at this map, it looks like, oh my God, like Alaska is like standing out as a state. Like, what is going on in Alaska? There's a lot of very reasonable questions that should be asked about native populations, about poverty and opportunity, a lot of other things going on. What is actually happening, what actually happened in Australia, in Alaska, I'm sorry, kind of the exact opposite. What actually happened in Alaska was in December of 2023, there was a massive spike in overdose deaths. The number doubled, and it was primarily young males who were of indigenous descent in a particular city. So the way that these numbers are reported nationally, once you have a peak like that, your numbers, the purple line there, stays elevated for nearly a year afterwards. So we really need to, I think the bottom line here is we can talk about what is theoretically happening at a national level in the United States, but what really matters is what's happening on the ground and locally, because that's where the more data are more accurate and we have a more complete picture of what's happening. So we've seen maps, we've talked about geography. And I think this gets to our kind of one of my last points here before I turn it over to Adams, which is this very fundamental question. In a large country, how much does geography actually matter? Here's the truth. Drugs don't sweep across the continent like weather fronts. Instead, it's more like skipping stones, where certain drugs end up in certain pockets and tend to be kind of more splotchy than across the country. So let me give you an example. So these are three cities in the United States. The population centers for these three particular cities of Maryland, Delaware, and the District of Columbia. I know DC is not a state technically, but we're going to call them a state because we just believe they deserve statehood. These are three cities that are 100 miles apart. You can convert that to kilometers, I think, but it's about 2 hour drive between these three places. And you would think that, on a country that is as large as the United States, that this kind of uh, micro environment might have similarities in geography. Maryland is the top one there, MD in the abbreviation. And so you can see their overdose deaths actually peaked in 2021, in early or late 2021, early 2022. Whereas in Delaware, which is right next door, their overdose deaths peaked in 2023 and into 24, whereas in Washington, D.C., the overdose deaths peaked in 2023 and later part of 2024. These are really different patterns. They're really close to each other, but the problems that they had with overdose deaths were actually separated in time by a few years. At the same time, that's looking at the red. If you look at the blue, you can also see Maryland and Delaware have come down from their average quite a lot. And, is that due to interventions? Is it due to drug supply changes, other things? But in Washington, D.C., just a few miles away, you see that their declines have been declines, but they have been nowhere near the same pace as in the other two places. So all of this to say, geography is a part of inference when it comes to drugs and when we think about what is causing overdose declines. But in practice, there's a lot more nuance, and drug supply chains are actually a lot more localized. So, Adams, turning it over to you. Is that right?
Yes, yeah. Thanks, Nab. I want to talk a little bit about our thinking about why overdoses might be dropping in the United States. If you go to the next slide, please. And one of the earliest things we saw after this news came out was a lot of self-congratulation and patting on the back across public health sectors. We did it, right? Our interventions are working. And for those of you in the audience who aren't scientists, even you'll know that correlation is not equal to causation. So we took a much more tempered view on the possible explanations. These are the eight reasons we kind of conjectured back in October that might be reasons for decline. And at that time and now we have feelings about which ones are more plausible than the others. But we wanted to start by talking about how we think through what the plausible explanations are. The reality is, the empirical data on why overdose may have decreased is just coming out. Studies are just being reviewed and published. And even then, there's not a great way to do ecological studies to tease apart the real causes, right? At a national level, we would need comparator countries, and there aren't any. And when we start getting to state comparisons, there are just so many factors that we would need to consider to really say that this is what caused the decreases. Next slide, please. So I'm going to give one as an example. That one of the causes that policy leaders kind of championed was that we have better drug treatment in the past few years. So what we want to do is think hypothetically, if this were a contributing cause, what would overdose trends look like? Next slide, please. And so we can think about, okay, if an intervention happens, this policy event, um, we should be able to map that onto trends in overdose. What did overdoses decrease suddenly? And did overdose decrease equally in different parts of the country? So a good example we can think about in the bottom right is if border interdiction efforts in the Southwest, so kind of trying to stem the flow of fentanyl into the country, if that was a real contributing factor, we would expect differential impacts in those border states where most of the fentanyl is crossing the border as compared to maybe some smaller states in the northeast part of the state that's further down the distribution pipeline. Next slide, please. So again, we'll look at policy changes in treatment. The biggest change in policy in drug treatment in the United States, arguably in the century, was the Data 2000 Act. That's the Drug Abuse Treatment Act. And what it did is before Data 2000, basically, if you needed a medication for an opioid use disorder, you went to a methadone clinic. You went to a specialized clinic that was registered and regulated to get treatment. Data 2000 changed that and said that certain providers could prescribe Schedule 3 to Schedule 5 medications if they meet certain requirements. And Schedule 3 to Schedule 5 are the quote unquote like less the drugs with less dependence risk compared to higher scheduled drugs. And the reality is the only drug that really qualified in that category was buprenorphine. And the original law said you needed to do 8 hours of training, you needed to register with the Drug Enforcement Agency, and that registration number had an X, so we call it the X waiver, and all of these other hoops you had to jump through. So not ideal. Sorry, previous slide, please.
Sorry.
That's changed through time. It's gotten better through time. The patient caps have increased. More providers have been permitted to prescribe. Um, until finally in 2023 in our Budget Appropriation Act, Congress said, you know what, we're getting rid of the X waiver. Uh, Now, what we would expect is this is a shock to the system. Now that the X waiver is gone, all kinds of providers should be going out and prescribing buprenorphine. So our hypothesis, next slide, would be that, okay, it's a national level policy, so we think it's probably going to impact different places equally or roughly equally. We might think that there's a little bit of a lag in the impact. You know, it takes time for providers to think about prescribing and then patients to get prescribed and then for patients to stay in treatment, et cetera. But we should see a rise in the number of patients who are being prescribed buprenorphine. Next slide. So here's the reality. If we look at the graph on the right, what you're seeing on the y-axis is the number of buprenorphine prescriptions dispensed per month in 2022 and 2023. And that vertical line in the middle is the date that the X waiver was eliminated. And what you'll notice is that the number of prescriptions remains effectively unchanged. Now, there's another graph we're not showing that shows that the number of providers prescribing has increased, but the number of prescriptions received has not. And so this is just kind of a cautionary tale about attribution. You know, in the absence of solid data, which we're still waiting on, we especially have to be humble and accept the fact that the causes of declines in overdose might not all have to do with public health intervention. Um, just some more ideas we've been kicking around or heard through the grapevine that we won't go through. We'll share towards the end what our hunches are, but just wanted to put that out there. Next slide, please. So I think one way we've been thinking about reduction is through a demographic lens. And if you go to the next slide, there's a theory in epidemiology called the depletion of susceptibles. And just to illustrate an example, if we imagine we have a school and there are 100 students at the start of the flu season, over time, a handful of students are going to acquire the infection and subsequently become immune. And depending on if you're in one country or the other, maybe more students are vaccinated than in other places. But So what's happening is the denominator of risk is changing. The number of students who now are susceptible to the flu is smaller because a number of students have gained immunity. Next slide, please. So we can apply this same concept to overdose. It's not an infectious disease, but it is a health outcome that people have a certain level of risk to. So let's imagine this is the folks who use drugs with overdose potential in the United States, and they're highlighted red because they have high risk. This is some point previously in the past, and then we zoom forward and we can think, well, what's changed between then and now? Well, people can leave that population at risk. That can be, sadly, people dying from overdose, but it can also be people entering treatment or naturally aging out of substance use. And then at the bottom, people can enter the population at risk. And we're thinking about mostly adolescents who might start experimenting with drugs, and also people who might return to use during treatments. And then we have the people who stay in the population at risk. And some of those people might have roughly the same risk over time, and others might have lower levels of risk. And we might attribute different reasons to those changes. So, for instance, the row that's highlighted in orange, maybe they've grown increasingly tolerant to the fentanyl supply. And that lime color, they've increased tolerance and they're engaging in more harm reduction behaviors. And so what we have on the right is not only potentially a lower total magnitude, the number of susceptibles, but among the susceptibles, their cumulative risk may have decreased as a result of policies or practices. Next slide, please. And so the way we can think about this is if we're thinking about causes, there are three avenues we can conjecture. First is that are fewer people entering the population at risk? Second, are those people who are already at risk, is their risk diminishing? And third, are the people who are there more people leaving the population at risk? And then we can frame it in two ways. And for those of you who have studied public health and health behavior, you may have seen the social ecological framework. Are we thinking about individual behaviors or community level changes or system level changes? So we can think about, is this a change that the system imposed, or is it a change that really came from the behaviors of individuals? And to give a few examples, um, an example of a systems level change that caused fewer people to enter the population at risk would be changes in prescription opioid prescribing. If there's more regulation of prescribing, perhaps fewer people are inducting into this population through prescription use. A behavioral change in the United States, we know that adolescents are engaging in risk behaviors less and less, and that includes substance use. We can think about the people already at risk. A system change might be a change in the drug supply. So for instance, one of our hypotheses is that the opioid supply is kind of stabilized in terms of the potency of the main molecules. We saw this jump from opioids or from prescriptions to heroin to fentanyl. And fentanyl's been in the supply for 12 years now. And so in some way, you might argue that there may be an increase in population level tolerance. And then at the behavioral level, of course, we think about, as all of us here do, harm reduction and behaviors to make ongoing drug use safer. And then the last example would be people leaving the population at risk. Explanations like better treatment access and retention. And then at the behavioral level, aging out of riskiest use. So we'll come back to what our hunches are, but while we're on the topic of demography, I'll hand it back over to Nab to talk about generational effects.
Thanks, Adams. Very helpful explanation there. So one of the things that we know happens in drugs across the world is generational effects. There are cohorts of people who use certain drugs for certain amounts of time, incur certain amounts of pleasure and pain from them, and then stop using and die of other causes. So one of the ways that this is a very complicated epi concept, but I think this news article actually did a really nice job of visualizing it. This is looking at drug overdose deaths in Black men in Chicago, and following, and you can see where the intensity of color increases is kind of across the lifespan. These are men born from 1951 to 1970 and who came of age right during the height of the crack epidemic. And these are people who were like heavily, whose understanding of drugs was one of violence and heavy stigmatization. And one of the things that could be happening is we see this trend in Black men, older Black men in multiple cities, in Philadelphia, elsewhere. And one of the things that folks on the ground attribute to the behaviors is and the systems is that people are less likely to seek help if they kind of came up through the violence of the crack era, and are kind of incurring, are not availing themselves to harm reduction and treatment resources the same way as their younger peers. So we can get into this a little bit more with our current data. So this is a figure that we are getting ready to publish later this week. And this is in pink up top is the number of overdose deaths and absolute number of deaths per year, for 2022, 2023, and in darkest purple is 2024. And what we've done on the horizontal axis is instead of looking at age groups that change over time, we're actually looking at birth years. So this is year of birth. So that's why the numbers are going to be lower than what you saw before. They'll sum to the total of 70,000 that we're experiencing now. But what you're seeing is kind of how many people in this year who were born this year died of an overdose in 2022 versus 2024. And on the bottom, we'll see how many fewer deaths are happening in 2024 versus 2022. And in the gray bands vertically are the different generations. So Gen Alpha, Gen Z, Millennials, Gen X, Baby Boomers, and even some of the silent generation. So what we can see, first of all, is that Millennials as a total make up the bulk of overdose deaths in the United States, followed closely by Gen X. As someone who kind of straddles those lines, um, these are my friends. These are people I work with and love who are dying. Um, there's other kind of things to point out, but in the interest of time here, I'll focus in on the right hand part of Gen Z, which I think you should be able to see my cursor. But right here, there is only one group of ages across the entire lifespan where we actually saw an increase in overdose deaths between 2022 and 2024. And this is the younger half of Gen Z. So specifically, so these are again like very fresh data, and we're showing you guys kind of for the first time. And so we haven't quite figured out a way to visualize this in a pretty way yet. But let me translate this table using these colors. So what's happened is the only group across the age span where we're seeing an increase in overdose deaths are kids who were born between 2005 and 2011. And these are kids who were in middle school and early high school during the COVID interruption to their formative education. Is that something that is going to translate into further risk in the future? Is kind of the question that we think is really relevant and one that we're not asking enough. Um, you can see in the green column, every like ages are like younger than them, which are up here at the top. You're seeing kind of no change or declines in overdose deaths, and above them, so in the bottom of the graph, these are the top half of Gen Z, the older half of Gen Z, and you can see their numbers are declining on an annual level quite a lot. So this is the kind of details that often get lost when we bin things and continue and categorize the continuous variable of age and try to put it into these age buckets, but these age buckets are shifting. I also want to point out this is a very small portion of the total. It is an important and heart-wrenching portion of the total, but it is, only like 1 out of 9 are in this kind of age group. So the bulk of resources we think should be devoted to Gen X and millennials and getting their risk down. But the Gen Zs, I think, also need help. I think the other thing that's interesting here is that when we think about the longevity of the opioid crisis in the United States, we're looking at things that happened 25, 30 years ago. Some of the most nefarious acts by the pharmaceutical companies happened in the late 1990s. Some of that stuff continued for a few more years after that. But what we're seeing is that this is a risk that has actually shifted across generations. This is not the same people dying of overdose death today are not the same people who are dying of overdose deaths by age group in the early 2000s. Okay, so putting this into context, like, okay, these are some fancy epi math numbers, but let's put some real world into this. And we're going to go back to that number of that 42% of people who have know someone who's died of an overdose death. This is the kind of corollary paper to that. There's about 1.4 million kids in the United States who have lost a direct family or family member to an overdose death. And if you look at, and these are data from 2009, so these numbers will probably be higher. The number one group are aunts and uncles. What I didn't expect was the number two group is grandparents. What we're seeing here is a generation, like multi-generational impact of overdose deaths in the United States. So I think this is you, right, Adams? Okay,
No, this one is you, but I guess either can
this is
take
me.
it.
Go for it.
Okay. We obviously celebrate the reductions in overdose deaths, but when we think demographically, um, certain groups are benefiting more than others, and this is a tale as old as time in the United States. In particular, Black or African American individuals, as well as American India, Alaska Natives, and Native Hawaiian Pacific Islanders are experiencing uh, uh, less pronounced declines, specifically than white folks in the United States. Um, a useful theory for those that want to do some extra credit reading after the webinar is a theory called the theory of fundamental causes. The punchline is that systems will find a way to continue to oppress marginalized groups even when interventions come to save the day. So um, clearly, there's more work to be done to support these populations.
In the interest of time, do you mind? Should I just like skip ahead a little bit? What do you think? We're at
Yeah,
just about 50 minutes.
yeah.
Cool. So just this is a really great podcast from our friend Philomena Quebec of the Bad River Tribe in Wisconsin. Encourage you to listen if you are interested in Indigenous experiences with overdose in the United States. Um, let's go to our take. I think. Do you want? Yeah, you're good at this. Go for it.
I'll be very brief on this. So we talked about some of the potential causes. These are again conjecture, but what we feel is that some reasons driving drops in overdose. One is drug supply changes. We've talked about perhaps the stabilization of fentanyl, but there are other supply changes, including the introduction of xylazine that I'll talk about on the next slide. Naloxone is saturating communities and specifically reaching people who will use it the most, which is people who use drugs. Um, and this is me catching myself in a lie. We talked about how treatment wasn't improving, but actually there are aspects of treatment that may be improving, including relaxed restrictions on teleprescribing and regulations in methadone clinics specifically. On the behavior side, as we mentioned, fewer adolescents are initiating use. More people may be engaging in harm reduction behaviors, and more people may be aging out. So again, we talked about this earlier. We can think about it as a systems change or behavior change. Are they two sides of the same coin? Do systems encourage behavior change? Perhaps. But one of our conjectures revolves around, as I mentioned, xylazine, which is a sedative that showed up in the supply. And we've talked to people who use drugs, and what we've heard is that xylazine is driving them to use less. They are um, uh, not feeling the euphoric effects they expected years ago, and it's also just knocking them out. Couple that with the risk of infection and amputation. As this participant said, who recently got on methadone, the methadone doesn't really do much for the tranq, which is xylazine. So that's why we're cutting down to a bundle. So they were going from 50 bags a day to 10 bags a day between themselves and their partner. I definitely think it helped in the success of letting the methadone work. Still didn't feel great for the first week, but now I feel amazing. And so the takeaway from this section is just that while we're celebrating the sea change in the overdose epidemic, we have to, again, remain humble because real causes may go beyond our public health interventions and may include shifts in markets and behavior changes that we didn't influence.
So in closing, there's one other part of kind of what is working and we don't acknowledge. And this is something we call invisible work. And there are literally like all across the country, every place we have the privilege to go to, we hear and find people who are doing amazing on the ground work. So this is in Lake Charles, Louisiana. They had a huge increase in overdoses coming into their hospital emergency room. And these nurses working with a partner group in California started doing buprenorphine dispensing, not dispensing, inductions right in the emergency room, and they were able to substantially reduce their overdose death rate. So look at these faces. I think, well, here's another example, and this is from St. Louis, Missouri, in the middle of the country, and where they saw a decline of overdose deaths by 23%, very much coincident with the ramping up of their naloxone distribution. What's really interesting about how they did it in St. Louis is that their rate of decline among Black residents in St. Louis was almost 46% for the same time period because they brought in, because people from the communities affected were the ones who were actually at the table designing the programs, doing the implementation. But I want you to take a quick look at these faces. I mean, what do you see here? We see joy that something is finally working. This is their slide with their title, The Why We Do This Work. The other thing that is very obvious to me here is that a lot of this work is being done by women. And a lot of this work of caregiving, of community response is being led by women, both in the clinical sphere as well as in harm reduction. And we clearly live in a society that undervalues chronically contributions made by women. And so when we have this counter narrative that is heavily dependent on guns and borders and interdiction, what we often leave out is this invisible work that is being done community by community by people who are part of those communities, and things they know things are working because they're seeing the changes directly in their communities. The numbers help explain what's happening, but when you go town to town, you will see faces like this doing the work and not getting the credit. So these are the things that we think, this is what we tell people in the United States of how we think of what we think public health is, of what we should be doing next. And I think we'll leave it at that. I want to just thank our team very quickly, and please sign up for our newsletter if you found this interesting. It's free and we won't sell your data, I promise. And we'll hope to be hearing from you guys. And if there's time for questions, we're happy to take those.
Thanks so much to you both. I love the intuitive way that you explain this incredibly complicated situation, and especially the way you interrogate the sort of causality or attribution question. And I really do commend people to go to the Opioid Data Lab site, and you can spend a lot of time on the post "Are overdoses down and why?" And really, it's just a model of how to think about these things and sort of interrogate your own assumptions or your own hypotheses, and really think intuitively about what data shows you. We are running a bit short on time, but if I may just be a bit provincial with one question here, which is, for countries like Australia and New Zealand, as someone in the chat asked, that have not yet, that have this looming specter of changes, of particularly of the arrival of potent synthetic opioids at a large scale. What should we be looking for, and how should we be preparing? Like, what do you recommend in terms of just both like monitoring and sort of public health preparation?
Right. Good luck. I mean, honestly, like the synthetic opioids have been such a terrible, terrible addition, like to the drug supply, has caused just an enormous amount of chaos. I don't know. I I don't know how to be prepared. I mean, y'all have methadone. Your policies are better positioned than a lot of ours were when fentanyl kind of showed up in force. Oh no, Adams would. You don't want this shit. That's all I will tell you.
I think that's a good response. I'm trying to answer some of the Q&As in text.
That's fair. Yeah, I mean, it's really, yeah, it's like it's the mix of looking at the data and then just keeping in mind that like some of these things are just just really forces of nature in some way. And I really appreciate that. There are a million questions we could get to, but we are relatively low on time, and it's well into the evening. It's into the night, even in summer in the U.S. So we would like to let you go, but I just like to thank you both so much for the incredibly illuminating discussion, and I really think people have learned a great deal. And I urge everyone to sign up for the Opioid Data Lab's monthly newsletter, which contains really useful info and sort of updates to everything that you've heard about today. I just also want to mention very quickly that Pennington Institute is the convener of International Overdose Awareness Day, held each year on August 31st, which brings a global community together to take action on overdose, as well as certainly serving as an opportunity to remember and pay tribute to people who have lost their lives, and the workers on the front lines who are out there trying to prevent further damage every day, while also spurring people to take action. So the more groups and communities that hold events, engage in other types of actions, the better. So please do visit overdoseday.com for more information and resources. Last thing, we do welcome feedback of people who attended today to help improve our sessions. So you can complete the Zoom survey that pops up. But overall, thank you both so much for attending, for the great presentation, for all your fabulous work across multiple sides, both with the data and the drug checking and the community engagement. And we really look forward to learning more from you as things proceed. And I hope the trend stays. And we will leave it at that for now. Thanks so much for attending. Thanks to our presenters, and have a great day.